Hello, and welcome to today's virtual forum, A Journey Home, Transforming Care, Providing Support, and Expanding Access. I'm Cecilia Oregón, or Ceci, the Executive Director of Kaiser Permanente's Institute for Health Policy. Our institute hosts events and publishes information to shape practice and policy on important health topics. We bring together experts to share their knowledge, spark discourse, advance our collective thinking, and explore public policies that can cultivate healthy communities and promote accessible, high-quality care. We're pleased to host this conversation today on a critically important topic, the need for everyone to have a place to call home. When we all have safe, stable homes, it's easier for each of us individually to maintain or improve our health status, and it's better for our communities overall. Unfortunately, too many people are struggling to meet their basic housing needs. According to the National Alliance to End Homelessness, in January 2020, there were over 580,000 people experiencing homelessness in America. 70% of those were individuals, and the rest that were living with families and children. These numbers are also pre-pandemic numbers and are likely an undercount. When people have high housing costs, they can be forced to choose between paying their rent or paying for food or other basic needs like medications. And for people who do become homeless, the situation is even worse. Chronic homelessness can cut more than a decade from a person's life. As a result of these long-standing systemic inequalities, communities of color are particularly likely to face housing challenges. Inequities have ranged from redlining, when the federal government used discriminatory housing loan appraisal systems that made it harder for people of color to access loans, to more recent inequities. For example, during the 2008 financial crisis, Black and Latinx borrowers were targeted by banks for mortgages with higher fees and interest rates than white borrowers with the same credit histories. Over the past few years, COVID-19 has added more financial strains, highlighted racial inequities, and worsened housing challenges. Communities across the country are struggling to help people who are currently homeless, and they're grappling with how to prevent people from falling into homelessness in the first place. Thankfully, there are efforts underway across the country to tackle these problems, and we're going to hear about a few of those today. To begin our conversation, I'm going to share a video clip from a short-form documentary series that Kaiser Permanente supported. The documentary was produced by KTF Films and Bread and Butter Films to highlight root causes of homelessness and promising solutions. Let's turn to the clip.
Well, I've been out here, man, off and on for about 10, 15 years. I'm not on drugs and things, none of that, that's what a lot of these people out here want to classify all the homeless out here, they're on drugs and stuff. I'm not on drugs or anything. Just turned 51 years old. I have income, not the greatest income, but I have income, but it's just no housing. You can go to the Los Angeles Housing Authority here in Los Angeles, and they don't even have housing.
The biggest crisis in homelessness is housing affordability. The rents are skyrocketing because the supply is so low.
There's market rate luxury housing. There's plenty of that. But when we talk about housing and homelessness, you have to build the housing to meet people's needs, and we have not done that.
The last voice in the video is one of our featured speakers today. All of our speakers will be discussing the housing crisis, including some of the challenges we just heard about, and they each have important perspectives to share. So today, we'll focus on what we need to do to move towards solutions. What roles can health systems play in addressing the problem, and where can policymakers intervene to support change? We know this forum will only scratch the surface, but we will get the chance to hear about opportunities to tackle the problem from several different angles. First, we'll spend some time understanding who is most likely to be homeless, the causes of homelessness, and how homelessness and housing instability impact health. We'll hear about intersections with root causes, including structural racism, and the need for solutions that get to the root of the problem. Then we'll focus on the importance of helping people who are currently homeless. We'll hear about opportunities to provide housing supports and services through Medicaid and other programs. And we'll hear about this from the perspective of doctors and care teams who are working directly with people who are coping with homelessness and its impact on their health. Next, we'll consider ways to prevent people from becoming homeless in the first place. And we'll hear about how legal assistance can play a role in keeping people housed. Then we'll hear more about some of the underlying structural causes of homelessness, with a focus on the current lack of affordable housing and how structural racism has shaped affordable housing access. We'll also tackle some of your questions. We've already received several questions from audience members during the registration process, and you can share a question in the chat box at any time during today's session. We won't be able to ask every question, but we'll try to get to as many of them as we can. So now I want to introduce you to our all-star panel of speakers. We're pleased to have with us today Dr. DiPietro, Senior Director of Policy, the National Healthcare for the Homeless Council, Dr. Rishi Manchanda, President and CEO of HealthBegins, and Jacqueline Wagner, President of the Solutions Division of Enterprise Community Partners. And to kick us off, we're excited to be joined by Dr. Margot Kushel, Professor of Medicine at UCSF and Director of the UCSF Benioff Homelessness and Housing Initiative. She's the Division Chief and Director of the UCSF Center for Vulnerable Populations and a practicing general internist at San Francisco General Hospital. Thanks so much for joining us.
Thanks for having me. I'm excited to be here.
So let's start by talking about the problem of homelessness. You bring several different lenses to this issue. As a physician who sees patients who are themselves dealing with homelessness and housing insecurity, and as the head of an initiative that conducts policy-oriented research about homelessness. So what should people know about who is homeless and why they're homeless?
Yeah, I think there are several things to know. And one is that despite what your eyes might be telling you, or despite some stories you might be reading in the media, we really know that the underlying driver of homelessness is the lack of housing available for extremely low-income renters. By that, we mean any renter that makes less than 30% of the area median income. And just for a sense of how bad this crisis is, in California, we only have 24 units of housing that are available and affordable for every 100 of these households, meaning we are short 1 million units. We have really strong evidence that the high rates of homelessness we see in the United States, and particularly the disparities between different regions, are caused by this disconnect between housing costs and people's incomes. And we know the devastating role that structural racism has played and continues to play in driving this crisis, such that Black Americans are 3 to 4-fold overrepresented amongst the people experiencing homelessness. Now, you might ask, how about those folks who have mental health or substance use disorders? I read about them, I see them, and there's no question that people with mental health and substance use disorders are more likely to become homeless because these disabilities interfere with so many aspects of life, and frankly makes it hard to compete in this really difficult housing market. But these folks are also the most visible. So they're the ones who sort of get the most attention. And we see a certain invisibility amongst so many others. We know a few more things. The population of single homeless adults is aging. Between 1/3 and 1/2 of single homeless adults now are 50 and older. But the modal age of homelessness in the US, the age you're most likely to be homeless, is 0 or less than 1. Those are the most common. And it really doesn't matter who you are who's homeless, if you have mental health or substance use disabilities, if you don't, if you're newly homeless or long-term homeless, the health consequences are so devastating. I like to say that there's no medicine as powerful as housing.
Wow. I mean, talking about sort of the populations that we perceive as visible and some that are invisible, these kind of misconceptions that we might have about who's homeless. How do we think about a different focus then, and bringing into light sort of those populations that are less visible?
Yeah, I think there are two things. One is we don't want to set up a dichotomy of sort of the deserving and undeserving homeless or deserving and undeserving poor. But I think it's important to know that we actually know how to end this crisis, but we don't have the political will to do so. What I like to say is everybody needs housing they can afford. And without that, to be honest, we're never going to end this crisis. Some people benefit from services and supports to enable them to thrive in this housing. We know we can do this if we lead with the housing. You might have heard sort of housing first, which is getting a lot of pushback now. Housing first is not a program, it's a philosophy. It's basically saying we can't really address the other inequities unless we start with the housing. Some people will need supports to stay in their housing. Some people just need housing that they can afford. But I think when we get into these conversations driven by sort of stigmatized belief about the most visible people homeless, we sort of leave everybody behind.
Yeah. And so let's talk a little bit more about how housing insecurity intersects with health. Could you talk a little bit about that?
Yeah, Matt Desmond, who wrote Evicted, says, without stable shelter, everything else falls apart. I might alter that a little bit to say without stable housing, everything else falls apart. The really interesting thing is we start to see the negative consequences of housing problems even before people become homeless. If you look at people who are paying more than half of their income in rent, if you look at people who are behind in their rent or mortgage, you start to see the impact on their health. And that just gets worse and worse sort of the further along the spectrum people are. But it really interferes with people's ability to make healthy choices, to get the food and medication that they need. It affects people's ability to interact with the healthcare system, the toxic stress of homelessness. We see incredibly high levels of victimization and trauma that's sort of reinforced again and again by homelessness. It really disrupts everything that leads to health. And to be honest, it really makes it hard for the healthcare system to engage in any meaningful way. Really, housing is at the root of health. And without that, everything else is sort of playing catch up.
So I know that you and your team focus a lot on research that can inform public policy. And we have some policymakers in our audience today. What are you learning that policymakers should know about?
Yeah, I think we're learning a few things. I mean, one of them I would say is that even the most behaviorally challenged people, even the people with the highest level of disabilities, can absolutely be housed successfully using these principles I've talked about of housing first. You need to start with the housing. That's the foundation to healing. When you offer people services and supports, they can remain housed successfully and begin to heal. We've seen that through experiments. So we did a large study in Santa Clara County where we intentionally tried to house the most difficult to house folks. We basically offered folks a 50-50 chance of getting housing. And basically everybody said, sign me up, even though we met people at the most vulnerable points of their lives when they had spent the night in jail or the morning in the ER. Everyone said, sign me up. We surrounded that effort with a team of a master's trained behavioral counselor and a peer, which is really important, and a bachelor's trained case manager. And we got over 90% of the most impaired folks housed. And once they housed, they remained housed for years, 6-7 years. I think that shows that we can do this if we stick to our basic principles. We've learned a lot about what is the best predictor of people becoming homeless. If you had to choose one, it would be being homeless in the past. And if we want to sort of focus prevention efforts, that's probably the most important part to focus them on. And then we've learned the importance of centering the true experts in this space. I'm called an expert, but I'm not an expert. The true experts are the people with lived experience, or as we like to say, lived expertise. And we've learned that if we listen to them and hear what their needs and their challenges and what they think the solutions are, we're going to get to the best solutions.
So it sounds like we know a lot of what works. So why do you think it's been so hard for us to solve homelessness?
I think that's a great question. And I think one of the reasons is we as a society don't tend to think deep and structurally, and we're expecting the homeless system to try to sort of solve a crisis that's really deep and really profound. I think it's important to note that, the federal government only funds 1 in 4 vouchers for people who meet the very strict criteria. That is a spend on the federal level that they could turn around tomorrow and fund the vouchers. Would that end every bit of homelessness? No. But is that essential to do it? Absolutely. We tend to blame the people most proximate to it. We tend to blame those with the most stigmatized conditions. We tend to criminalize this problem, and we don't tend to look at the deep roots of it. So I think to get to a solution, we're going to really need to really invest in a meaningful way in affordable housing, and not just affordable housing, but affordable housing for the lowest income individuals. And we're going to need to lean hard into these housing first policies, even when there's a lot of political blowback. We're going to need our electeds to stand strong with the evidence, just like we've asked people to do with COVID vaccines and other things, right? We need to lean into the evidence. This is an evidence-based, bipartisan, successful policy. And if it looks like it's failing, it's only because we haven't dealt with the underlying income inequality, the underlying deep lack of affordable housing, and frankly, the structural racism that undergirds so many of these policy decisions and so much of the crisis that we're in.
Thank you. And, just for our audience, folks might not be familiar with the Housing First frame. Would you mind describing that?
Yeah, of course. Housing First is really an approach. It's not a program. And what Housing First says is that in order to end homelessness, you need to start with the housing. And that housing needs to be offered without preconditions, that you don't need to, for instance, go to substance use treatment first, or you don't need to sort of earn your right to housing. If you do so, you'll leave people behind. If instead you start with the housing, and you make services that people may need completely voluntary, which is hard for people to understand. They're frustrated with people. Why should it be voluntary? But it turns out that if you give people the safety of housing and make the services low barrier and available to them, people take those services and people stay housed and thrive. So it really is just an approach that says that you need to start with the housing and do everything else secondary to that voluntarily.
Great. Well, thank you so much for joining us, Dr. Kushel. I look forward to talking with you more during our discussion section in a few minutes. So now we're going to explore some different approaches to housing insecurities and homelessness through 3 presentations. Our first presenter is Dr. Barbara Depitro, Senior Director of Policy for the National Healthcare for the Homeless Council. Dr. Depitro has been working in public policy for 20 years, and over much of that time, she is focused on issues related to healthcare and homelessness. She worked at the National Healthcare for the Homeless Council for the last 12 years. Before that, she worked for the state of Maryland in the governor's office and at the Department of Health, where she coordinated health and human services policy and legislation. We'll next hear from Dr. Rishi Manchanda, President and CEO of HealthBegins. HealthBegins is a consulting and technology firm that helps healthcare community partners improve care and address social factors that influence health. Their clients include the American Hospital Association and health systems across the country. Previously, Dr. Manchanda served as Director of Social Medicine for a network of community health centers in Los Angeles, and he was the lead physician for homeless veterans at the Greater Los Angeles VA. Next, we'll hear from Jacqueline Wagner, President of the Solutions Division at Enterprise Community Partners. Jacqueline leads a team of more than 300 staff across the country, and she drives Enterprise's programmatic policy and advocacy work. She brings experience in commercial real estate lending, spanning more than 24 years, working with cities, banks, and nonprofit developer partners. She holds a master's degree in urban planning from UCLA, and she serves on multiple boards, including the LA Homeless Services Authority Commission and the UCLA Luskin School of Public Affairs. And now let's turn to our first presentation, where we'll learn what we can do to support people who are currently experiencing homelessness. Dr. DiPietro, I'll turn the floor over to you.
Great, thank you so much. I really appreciate you holding this session and focusing on these issues. I just want to note that the National Healthcare for the Homeless Council is a membership organization, and we're supporting largely FQHCs and other healthcare providers who are delivering services to people who are homeless. And so with that perspective, bringing the role of providers who are working on the day-to-day basis with the clients that we serve in a team approach to be able to maintain housing. And so today, I just wanted to cover 3 topics. I wanted to talk about the policy vehicles that exist within Medicaid to add tenancy supports to your state plan. I wanted to talk about the challenges of this work every day. And I wanted to talk about the design of the benefit and some of the considerations that as policymakers, thinking about how to really frame this so that it works on the ground for the providers and the clients that we're trying to, again, make this happen every day. So if we can just go to the next slide. So want to highlight there are a range of options within Medicaid to be adding tenancy supports, these authorities that you can use for your state plan. I've highlighted 2 in red because these seem to be the most common. So an 1115 waiver or a 1915I home and community-based service state plan amendment. So those are the 2 most common. There is an unending amount of detail behind each one of these vehicles. And so we can do a deep dive here, but I think here I've put a couple of references and resources that you might have if you want to go deeper here. One, I will call out the MACPAC, Medicaid's role in housing. This is the Medicaid Payment Commission that really does an outline on what are the approved vehicles for this. And I also want to highlight that CMS earlier last year had put out a state health officer letter that outlines how you can incorporate social determinants of health into your state and into your state plan. And so between these 2, I think this gives you a good background for the options that exist. But I'd like to just give like an example. I'm sitting here in Maryland, and so there's a lot of different ways you can do this, and they don't always have to be statewide. So Maryland's a good example of that. So if you're in a state that may not have already moved forward in doing this in a comprehensive way, you might even think about this from a locality's perspective. So in Maryland, it's the local jurisdictions that participate in the waiver, and there's a number, so it's not all jurisdictions. And in Maryland, Baltimore City anyway, it's the hospital systems that are providing that local match to the city that then provides the state match in that traditional way. And so that gives health systems a really good footing for their vested interest in making this happen and participating in some of these improvements. I can just say that here in Maryland, we've had this waiver for a number of years. It's just been reauthorized. And actually in that reauthorization, we went from 600 slots to 900 slots. Now at Healthcare for the Homeless in Baltimore, where I'm based, we're the service provider for the city, and we've got 200 of these slots where we're supporting clients in their housing. And so while there's a formal analysis that's still being done, we just looked at 85 clients that over the course of being housed over a year, we found that there was a 54% decrease in the number of hospital visits, a 69% decrease in emergency department visits, and an 87% decrease in hospital readmissions. And that was just from one small cohort after a year in housing. And so thinking through, you can really have a lot of flexibilities and options for how you can incorporate these benefits into your plan. And then finally, I will call out a really wonderful partnership, a publication from our partners at Corporation for Supportive Housing. They've done a great summary of state actions. So if you're interested in seeing what states have done, this is a really great tool, and they do a great job over there. Next slide. So I want to talk a little bit too about the clinical and client challenges that folks that we see on the ground every day. And so part of this is there's a lot of attention that gives toward getting someone into housing. And I think that in that push to identify the units, identify the housing, do the match and get your client into the unit, there's this tendency to think that once you've got a house key, all of the problems are solved. And now it's just going to be like Wizard of Oz and everything is in color and it's going to be wonderful. But in many ways, this is where the work really starts. Because after you've got the moving in party and everyone's excited, you have a very vulnerable client, and most of the time a case manager or someone else in the care team that are basically by themselves to figure out, okay, how do we make this work every day? So that's where really the work starts from a support services perspective. And so I just wanted to highlight a few clinical challenges here that we see in providing the supports. Part of this is adhering to medication and treatment plans. It's not unusual that our clients are on maybe 10, maybe 12 different medications. They have a fairly complicated medical plan or healthcare plan to follow. And so thinking about how you're going to implement all of those pieces and engage your client in that plan is very important. I've highlighted here a planning for relapse and setting reasonable goals, because this is a really important one. So first of all, we have to just understand that relapse is part of recovery, and that people don't often have a smooth transition into being abstinent, if even that's the goal to begin with. And so a lot of times, even a small thing can really throw your client off. So it may be that you have a client you've been working with and he's doing fine, but then maybe his mother dies. Maybe he sees a violent, act or a crime on the street, and that triggers his trauma. And all of a sudden he's gone from, checking in with a case manager once a week to needing someone every day because he's in crisis. So how are we creating the care teams that are flexible enough to be able to respond to clients in their day-to-day needs and be able to be ebb and flow as our clients' needs ebb and flow? So I think that's one of the pieces I wanted to say. And then also setting reasonable goals. If you're taking someone who's been homeless for 20 years and sleeping outside and has a lot of significant healthcare issues, it's unreasonable to expect that within 6 months or 9 months, he's going to be fully employed and president of the PTA. Like, that's just probably not going to happen. So thinking about really what's reasonable to expect from the goals we set from our clients, because when we set them up to fail, then we've all failed this client. There's a number of other things here that we can talk about, but I just want to move on to a couple client challenges. When we talk with our clients about the struggles they have in transitioning to housing, they talk about the loneliness and the isolation of being in housing, particularly when many people come from being in a lot of congregate settings, whether that's an encampment or a shelter, or usually you have a lot of people that you're, together with. And sometimes it's really isolating when you go into a unit and you're alone. And this also raises, risks for overdose, risk for some of the other things where it's just a safety issue. So there's, again, so much more we could talk about here, and we can always come back. But I do want to also mention that at the bottom here, we just put out one of our clinical publications, Healing Hands, that talks about the challenges and opportunities of housing transition. So I offered that as some additional reading as well. And then we'll go to the next slide. And so finally, just wanted to talk about benefit design and some other considerations. So if you're working in a system that's trying to either implement tenancy supports or improve what you already have, thinking about a number of these things that can make the benefits that are incorporated into the policy work in practice for providers on the ground. And so obviously maximizing your Medicaid reimbursements is really great. But I highlighted again 2 here that were really important: establishing manageable caseloads with appropriate care team members. It takes an interdisciplinary team with a lot of credentials across the team to be able to support very vulnerable people. And so this is everyone from peers and community support work, community health workers and case managers, to nursing, physicians or nurse practitioners or other providers or behavioral health providers. And working together, people can meet the various needs of a client. But again, thinking about making sure you've got someone on the team who knows what to do if you do a house visit and your client's pills are dumped out all over the table. What do you do? If you have the only person on your team that's able to respond is a case manager who may not have the medical training to be able to work through all of that, then that's going to undermine the success of the model. So really investing in the team members that you need so they can meet the needs. And then finally, I would, again, a lot to talk about on this slide, but I'll talk about intensive staff training and support. So a lot of this is about helping the staff be in the job so they've got training and motivational interviewing, harm reduction, trauma-informed care, but also giving the supports to stay in the job, because a lot of turnover also undermines the success of the model. And so thinking about how we're supporting our clients and our staff in secondary trauma, grief, or crisis counseling. Don't forget, it's a lot of our providers who are doing a home visit and may find a client deceased. And that's very hard on the team. And so thinking about how we're supporting the team for the longevity there, and then allowing for the supports, again, that they need to keep them in the job. And just finally want to say that we remember that homelessness is really hard on the mind, the body, and the spirit. And so when our clients are 50, often they are presenting as a 75-year-old, and they've got the healthcare needs, the social support crisis needs, and just frankly, the team needs that someone who's really elderly needs. And so just thinking about that from when we design these benefits will help support the providers and the patient and the clients who are really making this work in the day-to-day. I'm happy to come back to any of these points in the discussion, and want to turn it back to you, Ceci. Thanks so much for having me.
Thanks, Barbara. That was wonderful. And now that we understand some of the opportunities to help people and some of those conditions for success, let's think about the opportunity to prevent homelessness in the first place. So for that presentation, we're joined by Dr. Manchanda. Rishi, I'll turn the floor over to you.
Thank you, Ceci, and thanks everybody. Truly an honor to be here with you guys. My name is Dr. Rishi Manchanda. I'm an internist and a pediatrician, public health trained, and the bulk of my career has been spent providing care alongside colleagues and for people with lived experience and expertise, as has been said, especially those who are living in historically marginalized communities. HealthBegins is an organization I founded in 2012, and our work, as Ceci mentioned, is to help health systems and health plans, along with community partners, address the social and the structural drivers of health equity. And so what I'm going to speak about today in my few minutes, so we can get to go through our next presenter, who's wonderful, and the discussion, is just a few talking points. No slides, just elevating equity, rights, justice, and place. So equity. Increasingly right now, healthcare systems, and what I'll be speaking to is with those lenses, by the way, how equity, rights, justice, and place implicate the possibilities, the opportunities for healthcare systems in particular to be able to now address homelessness and also help prevent it in the first place. So from an equity perspective, we know, for example, that in states like California and across the country at the federal and state level, more and more payers, federal, public payers, Medicare, Medicaid, and certainly commercial payers as well, are looking at how to identify racial inequities, starting with the collection of data on race, ethnicity, language, and then being able to stratify key performance measures, clinical measures, like how are we doing with utilization of the emergency department, or how are we doing when it comes to access to preventative treatments or preventative services or treatments. Increasingly, what states are doing and what payers are doing is asking healthcare systems to be able to identify whether there are racial, ethnic, or linguistic inequities in healthcare. That's a huge, necessary, and vital push. One of the opportunities that provides, especially for healthcare systems who are now marshaling resources and investing more in thinking about how to center equity in their work, is the ability to start looking at not just demographic information on race, ethnicity, language, along with other demographic information like sexual orientation and gender identity, but also to look at other filters, other data, to be able to understand patterns of inequity better. And there's no better category of data to be able to understand the drivers of inequity than social risk data. And chief among those, of course, is housing instability and homelessness. One opportunity right now that we're seeing, especially in health systems around the country, is the ability for health systems to better align their work, this newfound and necessary surge in interest in measuring and improving equity, helping them to understand how to take social risk information, including housing instability, and start to use those filters to be able to better define what patterns of inequity look like, especially to define what the drivers of inequity are, particularly when it comes to racial inequity. So when it comes to the work of healthcare systems to be able to address homelessness, it starts with just understanding that this work is about the core issue of equity, as people are embedding equity into quality and safety efforts, as community benefits leaders and population health managers and clinical care coordinators are starting to think about how to frame equity. Housing has to be front and center in that conversation because of the significant driver, as we've heard already, that it has on health outcomes and health equity. The other thing I mentioned was not just equity, but rights. And so when it comes to healthcare and certainly for housing, I think one of the main challenges, and this has been spoken to before, that we have right now is that we view healthcare and housing as well as primarily a commodity rather than a right. And that's not just a slogan. It actually has real concrete implications. Leading advocates and scholars like Eric Tars and others have written extensively about the opportunity here and the need for the U.S. to be able to fully understand the right to housing and how that needs to be codified in law to be able to afford protections to everybody so that everybody can truly realize the right to housing. That doesn't mean everybody in America gets a free home. The right to housing is ensuring that everybody has opportunities, equal opportunities to be able to get access to housing. And of course, we know that that's particularly important right now because of the legacy of structural racism. From a rights perspective, the healthcare system actually has an interesting role to play. We can look at our patients not as just as beneficiaries of services, but as individuals with rights, and ask ourselves, in addition to providing the right and delivering the right to healthcare, what other rights can we help to identify and preserve and protect, including the right to housing? One of the best ways to be able to do that, as we found, is through medical legal partnerships, which is my segue to the justice opportunity. What I've learned in my career, having been a medical champion for starting medical legal partnerships in two settings, one in South Central Los Angeles at an FQHC and another at the VA here in Los Angeles. And now with work that we're proud to do alongside the National Center for Medical Legal Partnerships and Kaiser Permanente through a bold initiative called the Health, Housing, and Justice Initiative. What we're now seeing is that medical legal partnerships, of which there are now more than 450 in almost all states in the US, these medical legal partnerships that bring lawyers, often public interest lawyers, into healthcare settings are an opportunity to be able to align the ability of healthcare providers to provide healthcare with legal specialists, lawyers, to be able to provide access to justice. And what that unlocks is the ability for healthcare to do a better job at being able to deliver better outcomes, address inequities, and then for lawyers as well to address the key drivers that often prevent individuals, especially those who are experiencing homelessness or those at risk of homelessness, from getting better. MLPs, medical legal partnerships, are powerful tools that I can personally attest to as a doctor. It's when I've had a lawyer in practices that I've been in, lawyers have made me, this is my punchline for the day, if you take nothing else away from this, lawyers in my practices have made me a better doctor. And there's not a lot of doctors who talk about the doctors and lawyers kind of coming together. It's often dogs and cats in the way it's framed publicly, but public interest lawyers through the MLP model have powerfully unlocked the opportunity for us to achieve the quadruple or the quintuple aim in healthcare by virtue of being able to address those legal needs, those housing issues in particular that drive poor outcomes for our patients. And that's exactly what's happening now with KP that we're proud to see across the country as Kaiser Permanente now scales MLPs throughout its footprint across the country. What we're seeing is that MLPs are now able to help the medical side of the house understand how to provide better services, but also be able to identify the institutional and system barriers that can then inform advocacy efforts more broadly. So equity, rights, from a rights perspective, preserving justice. And justice happens, as I'm seeing day in, day out, and I think many of my colleagues here can attest to, more and more through the abilities for MLPs to be able to unlock and connect those aspirations. The final thing is place. Much of what we've done in healthcare is to decouple the pursuit of healthcare and the accountability for healthcare from place. We impanel patients. We have payers who tell us about which populations of patients to do better for and attach incentives to that. But very rarely does healthcare in the US now have any accountability to improving outcomes by place. One of the opportunities that we have in the value-based payment kind of movement that's taken place in the past decade, and increasingly as people look at how to embed equity measures into value-based payment, is to start to situate that work within place-based payment models. How do we start to align outcomes-based financing, social impact bonds, other vehicles of place-based financing to improve health outcomes for a population in a given community, and align that with the value-based payment efforts that are helping providers of care to be able to improve outcomes for patients? That alignment opportunity is something that policymakers in particular are well poised to be able to support. And that's where, especially with your medical legal partnerships and through a lot of the work of housing advocates and organizers and service providers, we can come together and start to align some of these efforts And that's a huge challenge that we have right now. The incentives from a state and federal level just don't allow for us to really think about how to align service providers, be they healthcare or legal or social providers, to be able to come together in place. There's an opportunity, a huge one, to change those incentives. The final thing I'll say really concretely is that in California, for example, and as has been mentioned across the country, Medicaid waivers and transformation is creating a huge opportunity. In California, there are 14 community support services that California itself, the state, is now making available under Medicaid to be able to provide cost-effective alternative services in lieu of traditional medical services, services like housing tenancy support, services like housing navigation support, and so on. A huge opportunity in my final seconds here for the state of California, and I think for the rest of the country, is for policymakers to make very clear, provide clear guidance that medical legal partnerships are an opportunity now to provide those types of housing support services to unlock the potential for MLPs to provide even more access to justice and to better healthcare for millions of people who are now more than ever at risk of homelessness. Formalizing MLP, providing guidance and support to see how MLP is part of the community supports package in Medicaid in California, much like in other states, can be hugely powerful to help scale that opportunity.
Thank you, Rishi. Wow, equity, rights, justice, place. Those are words that we'll be taking away with us today. So for our next presentation, we're joined by Jacqueline Wagner. Jacqueline, we'll be turning over to you now.
Well, first of all, good morning. And how exciting is it to hear doctors talk about housing? I mean, I'm so excited to be here today. So good morning, everyone. I'm Jacqueline Wagner. I'm the president of the Solutions Division of Enterprise Community Partners. We've been around for 40 years, ensuring that everyone in the country has access to stable, affordable, healthy housing. To do that, we work in partnership with hundreds of community organizations across the country. We advocate for good policy at the state, local, and federal level. We invest capital to create and preserve affordable homes, and we own and operate affordable housing developments and provide resident services to 22,000 people. One thing that has become clear throughout our 40 years of working on this issue of health, homelessness, and affordable housing, they're all deeply connected. And that's why I'm so glad that we're here today speaking and learning from everyone here on this panel. Another essential fact of this work is that all of these challenges are systemic. They are rooted in racial and socioeconomic inequalities that directly impact the way our communities were built and what they look like now. Doing this work means that engaging in systems change, and it seems recognizing and addressing the inequalities that these systems have created. For enterprise, that begins with housing. We believe, and research has shown, that having a stable home is the essential platform for a good life. Without one, it's incredibly difficult to get and keep a job, stay healthy, and pursue an education or build a community. We live in a country where 1 in 4 renters, that's 10.5 million families, pays more than 50% of their income in housing costs every month. And that was before COVID-19. And we don't have nearly enough affordable homes to meet the need. Only 37 rental homes are affordable and available for every 100 low income renter household across the country. The affordable housing shortage has a direct impact on the homelessness crisis. Nationally, the number of people experiencing homelessness has increased every year since 2016. This is a tragedy and a failure of the housing system in this country. And it's another crisis with disproportionate impacts, which you've heard about a little bit already. Native Hawaiians and Pacific Islanders are more than 6 times as white people to experience homelessness. Where I live in Los Angeles, Black people make up 9% of the population, but 40% of the homeless population. This is a nationwide trend. It's not new. Black people and other people of color are overrepresented when it comes to homelessness. Again, these figures were before the pandemic. When we talk about ways to bring people off the streets and into homes, we have to think holistically and long-term. It's been said before me on this panel, and it's still true. We need housing plus services. Any strategy that doesn't include housing is incomplete. Fortunately, we know what works, and there are proven long-term solutions to homelessness that are waiting to be scaled across this country. The methods people put in homes as a first step, as you heard earlier, that makes the home a hub, and services and supports that need to be back on their feet. The Urban Institute recently released the results of a 5-year study on a supportive housing program in Denver that Enterprise helped to create. Next slide, please. The study found that in 3 years after entering supportive housing, residents experienced a 40% reduction in arrests and a 40% decrease in emergency department visits. This is a very big deal. The Denver program was also able to offset its own public costs by 50%, in part by decreasing people's interaction with the criminal justice system and emergency health care. It showed that investing in housing has a ripple effect that impacts public budgets in many ways. As the homeless numbers go up, there's a lot of talk about what to do about it and who's responsible. But we need more action, and we don't have to start from square one. We need to scale solutions like supportive housing across the country to help people experiencing homelessness now and prevent them from becoming homeless again. We also need to do absolutely everything we can do to get upstream and prevent the millions of families who are paying more than 50% of their income for rent. And we want to prevent them from falling into homelessness in the first place. Next slide, please. Housing, as you've heard from the prior panelists, is a direct impact of health. I heard Dr. Kushel say that housing is medicine. Our board member, Dr. Megan Sandell, says the same thing. Housing is a vaccine. Housing is most Americans' largest expense. We've said that. But if their rent is so high, they won't have any resources left for other necessities like healthy food, medicine, and preventive care. And looking beyond affordability, there's so many ways that where you live impacts your health, air quality, the age of your home, and the surrounding neighborhood all play a role. Inequalities exist in health and housing as well. Black and Latino households are nearly twice as likely as white households to experience housing insecurity and the health consequences that come with it. There is so much that housing organizations and health systems can do to partner together to improve people's lives. So let's get to the solutions as we wind down here. One, the example I gave you, Denver is a good example that should be replicated. Enterprise has helped create affordable homes on properties that are connected to hospitals, are connected to federally qualified healthcare centers. We design homes that have doctors' offices on site or that provide free transportation to care services. And we've encouraged housing developers to think about housing plans before they design and build assets and not do it after the fact. We're also encouraging developers and communities to build with health in mind. We run the Enterprise Green Communities Criteria, the first national certification program for green and sustainable affordable homes, which places a high priority on resident health. And we've heard from both health practitioners and residents participating in housing programs that bringing health and housing together is sure to get us on the right track. People often ask, how do we do all of this? Financing. There is a critical program called the Low-Income Housing Tax Credit Program that has built 90% of the affordable housing that we see in the country, resulting in 3.6 million homes. And if policymakers continue to expand this program and low-income housing tax credits, we can see another 2 million homes over the next 10 years. So what I'm saying, that it's essential that we use these tools. And what's exciting about these tools is they include public and private partnerships. And as California homelessness crisis has grown, we've had good partners like Kaiser Permanente working on Project Room Key and the Governor's Home Key program, which have successfully brought people into shelter and begun to create permanent housing across the state. And as I've said before, creating these types of homes that we're talking about that are affordable, safe, and healthy homes that meet people's needs has a cost at every step of the way. And as the Denver model shared, is that when you have these models where you are bringing people indoors, it saves money from people visiting, the emergency rooms, being arrested. It saves us all resources, and it helps people that need it the most. There are financial costs of not doing this. There are community costs, and there are human costs. And really, it's about serving our fellow Americans and other people that that really need the help, and to prevent people from falling into homelessness. And finally, while all of these challenges exist, I'm hopeful, because guess what? We're talking about it today. We're moving from talking, and we're taking more action. And there is really a lot of power with all of the people here today of taking that public-private partnership to scale to solve homelessness. Thank you.
Thank you, Jacqueline. Wow, really powerful presentations. And at this point, I'd like to bring back all the presenters onto the stage and have a discussion. And we've been getting questions from the audience and that were submitted before today, and we've had a few roll in over the course of the conversation. So the toughest part of being the moderator is how to prioritize all of these incredible questions. I do think there is one that I do think I'd like to start with that just came in, which is, to what extent do structural policies that contribute to high incarceration rates for BIPOC communities contribute or interface with homelessness? For any of you.
I mean, I'm happy to take that if that's useful. I mean, we know that, and we found from our research that having a record on your, catching a charge, having a record impacts you throughout your life, right? It both impacts you in your ability to gain employment. It definitely impacts you on the housing market, where it is often used as a strike against you. It impacts you in benefits and access to benefits, many of which you're excluded from if you have certain charges. It impacts your ability to move in with your family or friends, because there are all sorts of laws and statutory rules, some of which are true and some of which are almost like a fear that isn't necessarily true, but if people believe it to be true, it's true. And then there's just the trauma that people experience when incarcerated. We really can't separate out the way that our criminal justice system engages in completely discriminatory practices that lead to this over and mass incarceration of Black and Brown people, and how that ties into the homelessness crisis. So I don't think we can disentangle them. And I think that's yet another reason why those of us in this field are so appalled by the criminalization of homelessness, because what we see is not only do people who have records are so much at higher risk of homelessness, but then once they're homeless, they get picked up and sort of incarcerated for the fact that they're homeless, which just replicates the crisis. And this is how we wind up with, LA having 40%, right, of the population of people experiencing homelessness are Black Americans. It's hard to disentangle that with unjust, racist, and discriminatory criminal justice policies combined with other policies. So I think it's a really important discussion to have.
Okay, thank you, Dr. Kushel.
Can I plus one that just briefly? Oh, there's
Absolutely.
a lot. Barbara, please go ahead.
Oh, thank you. And I was just wanted to add to what Dr. Kushel had said by saying that from a healthcare perspective, incarceration also will fragment people from their healthcare provider. And so a lot of times there's a lot of disconnects that come with that. You get disconnected from your care plan, your provider, your medications. And a lot of times the treatment that you need and may have been receiving is not available behind the wall. And so particularly for medications for supporting opioid use disorder or other types of medications where you may go in, be incarcerated and have a complete, healthcare crisis and not have access to your medical records. When people come out of incarceration, we often as outpatient providers can't get the records of someone who's been inside behind the wall for a long period of time. So we're rebuilding everything from scratch. And I would take this opportunity to say that from a Medicaid benefit design, we really have an opportunity to connect people to Medicaid benefits and transition people on that reentry a lot more smoothly than we currently are. And so connecting people to a provider prior to coming out provides a more smooth transition, both for the client and for their healthcare, and also yields better outcomes. And I will say that in the Build Back Better legislation that's in Congress right now, there is a provision that would have 30 days of advance eligibility. So you've got the opportunity to get someone enrolled and get someone a smoother transition out of incarceration. I think this is really important from a healthcare perspective.
Rishi, you wanted to chime in?
I'll do a quick +1 or +2 to the prior comments here and just underscore maybe a couple things for dramatic effect. The U.S. imprisons more of its population than any other country as a proportion. And the hyper-incarceration phenomenon that Dr. Kushel kind of spoke about right now is particularly true, right? It's the manifestation of structural racism in the fact that there's disproportionate rates of incarceration of BIPOC communities. But the flip side of that as well, just to give a statistic that blew my mind when I heard about this, that point that has been made about the barriers that then are faced by anybody who has a criminal history. There are researchers estimated that there are more than 19,000 local, state, and federal laws that currently prohibit access to employment opportunities to people with criminal histories. And that's apart from the additional, local, institutional level kind of prohibitions that often exist, whether it's access to housing or employment opportunities locally, receiving public benefits, et cetera, that exist. So there are 19,000 laws that currently prohibit people who have a criminal history from accessing employment, which of course is is very closely related to housing stability as well. And so it's structural racism manifest. The other thing, though, has been spoken about is some people get overwhelmed by that number. It's jaw-dropping, but then it creates a sense of, well, what do we do about this? And I just want to underscore, when people often put their hands up in the air, like, well, structural issues, those feel big and deep and vast and historic. How can I, as a healthcare professional or a service provider of some sort, address those? The first recognition is that there are typical, very, very concrete mechanisms by which structural racism manifests in operations, and it was spoken to. One of them is the fact that there is no transition at all, right, from those who are incarcerated to the healthcare system. And so I just want to give a shout out to our friends at Transitions Clinic Network, which is a wonderful model that addresses, I think, the very issue that was spoken about just a minute ago, that purposely creates care models that are designed to be able to counteract those concrete mechanisms of structural racism. The more we in healthcare can design care models that are specifically and explicitly targeted at counteracting concrete mechanisms of structural racism, the more we'll find better models of care.
Great. Thank you. So we have a question, I think, that may be a complement to this, which is the audience member wrote that they are heartened to hear more experts and policymakers issue a call to action to include people with lived experience in policymaking. What they haven't seen is a clear framework for how to do that. So the question is, how can we operationalize this in a meaningful way for this issue? And are there examples of policies or programs that have integrated lived experience well? And it feels like this is a critical issue in terms of understanding the lived experience in a way that policy change and practice changes are supportive and not actually more damaging.
Oh, sorry. But no, please, Jackie, please start. Jackie.
I was going to say, we will not solve homelessness for anyone without lived expertise at the table. We've been trying to figure it out by ourselves, and look where we are today. And so it's essential that we develop advisory tables, people that are part of outreach teams, program design to help shape that path. And I will say the homeless industry, I know in LA County is doing it, but I know across the country, there's lived advisory boards, and they're taking the input from these experts to help refine and improve what we know works. And I will say that there's a lot of great lessons learned from probably Barbara's organization and a host of other agencies. You can for sure look at a number of the COCs around the country. They're integrating that work. So it is possible, and it's necessary that we do that as a path forward as a country.
I can even add to, I'm really proud of the Consumer Advisory Board model that the FQHCs that HRSA supports provide, particularly in the healthcare for the homeless programs. And so Consumer Advisory Boards, or CABs, are groups of patients that come together at their health center to guide the operations and the services of the health center. So this is in spirit of a community health center. The community is the patients that you're serving. So a lot of times in FQHCs, there's a requirement for those to be 50% of your board. But recognizing that that may not always be possible, particularly with a vulnerable population, it's how are you really meaningfully engaging the patients that you serve in a feedback mechanism to ensure that your services and your approaches are working for them. And this could be everything from the hours that you're open to the places that you're delivering services to the nature of the services themselves. And I would echo that a lot of times too, in the healthcare industry, we like to think that we are always helpers, but in coming back to a theme here of particularly structural racism, we need to understand that the healthcare system has also been racist to our patients, and that alienates folks and is not good for care. And so we have to be trustworthy providers in order to engage the trust of the people we serve. So I'm really excited about the CAB model being a replicable model, but I also would encourage policymakers to make the space for people to be able to come forward and share their expertise and to make the time for that to happen. And so making that in a time that people can actually turn up for that and giving the space for people to express themselves. And some of this may be expressing in non-traditional ways. Giving the patients in the space for that as legitimate feedback, I think, is really important for being inclusive.
Great, thank you. So we have a couple of questions that have come in around roles, for example. What can researchers do to help with this housing and homelessness crisis? We also have a question about what can disability rights lawyers do to help in this crisis. So curious if there's thoughts about specific roles that people can play where there's need still. Thoughts?
I think we as researchers need to do a few things better than we've done them. One is to really meaningfully include the voices of people with lived expertise in every aspect of our research, not sort of tacking them on as a cab at the end, but sort of developing research agendas, questions, administration, sort of from soup to nuts with people with lived expertise. I think the other thing we can do is to practice being better communicators. I feel like we're in a sort of anti-research, anti-science moment, and we have to own some of that for the jargon that we use and the complicated ways that we say. I also think, though, that we need to be courageous. I can tell you personally, it's an uncomfortable time to be sharing research on these completely evidence-based principles of housing first and the role of harm reduction and obviously what seems to us so obvious, the role of medication-assisted treatment for people who have certain substance use disorders where, not using those medications is akin to not using insulin for diabetes. It just doesn't even make any sense. And yet we're getting sort of pummeled with really loud voices who are speaking against this. So I would say include in a meaningful way people with lived experience. If we don't do that, we're going to get the wrong answers. Be better communicators and be courageous and stick to the evidence and not shy away when we're getting pummeled by people who are speaking against the evidence. This is really, homelessness is a structural problem and a political will problem. We know how to solve it. And so the role of research here is really just to keep pushing back against these extremist narratives. Mm.
Well, let's see, we have another kind of similar question about metrics for demonstrating success, or as Dr. Kushel was sort of mentioning, using the research and pushing with the facts. So how can we measure the value and the return on investment of reducing housing insecurity and providing housing support?
Well, I think the Denver model was a good example. You know, you saw a reduction in incarceration, you saw an reduction in expenses. It is much more cost effective for us to make sure that people have access to stable housing. We want to get better and recover from COVID-19. People need somewhere to sleep at night. So ultimately, it costs us more money to do nothing. We have to spend the money to house people and provide them services. There's no other way around it, because everyone that's probably listening here probably had somewhere to sleep last night, right? And you're able to get healthy, get the things that you need, and other people need that too. And I think that the cost of not doing it is humanitarian and also resources. So I think there's no other option. And we're learning the hard way through the pandemic that we need to do that. And I think that measures such as, you know, the work that Kaiser's doing around Home Key and other efforts are what we need to do to treat people with the dignity and respect they need so that they can be housed and get the services they need and want. People want to be helped. They want the opportunity to work and take care of themselves. But because of all these historic inequities that we talked about, we even touch on redlining and fair housing and other things that got us here as a country. And we have to do something to repair that.
Yeah, if I can build on that. Oh, sorry, go ahead.
No, sure, go ahead, Rishi.
Just, I shared a link in the chat, which perhaps will be shared with the broader audience, around a really wonderful resource that's very timely from our friends at the Commonwealth Fund around capturing the value of integration of social needs interventions in primary care. And you'll see in that examples of a medical legal partnership in particular as a case study. And one of the things that is nicely summarized in that report, and that it, you know, is consistent with the work that we've done, is to recognize two things. One, Jacqueline, to your wonderful point, there's when somebody says, what's the return, what's the value of X? The question first is, what's the reference point? Is it for a community? Is it value for a community, for a society, or is it for a particular set of beneficiaries for a program and the institutional, you know, the actors who are funding that? Oftentimes it's a mix of both. And so clarifying that is the first step we find, like, who's asking the question about what the value is. And oftentimes the answer has to be both. There has to be, for medical aid partnerships or for housing interventions in general, return value that's demonstrated at the programmatic level for those who are trying to provide services at the downstream kind of level, and then increasingly value that's articulated at the community and societal level. One of at the programmatic level for housing services, I think they're the big four value propositions that are always really helpful to articulate, as we've seen in our work. One is, what's the value proposition of increased revenue, especially under value-based payment kind of models? What's the value in terms of decreased expenditures, cost savings? And the MLP model in particular, especially in other housing services, have been shown time and again to demonstrate some of these returns in terms of decreased expenditures because of decreases in utilization, preventable utilization. The third one is improved operational efficiencies. We don't often capture that when we're trying to implement programs. We don't often say, the value of this is that you're going to do your job better, not just like X number of dollars that come into the bank for a particular healthcare system or social service agency. Operational efficiencies is a really big one. And the last one is, of course, value to the community. I will say that there's two things really concrete here. One is we have to provide the rates to be able to support the caseloads to provide housing services. And right now, as people are integrating more and more at the policy level, policymakers have a good opportunity here to really evaluate with rigor and the research expertise that's on this line to really evaluate whether the models of integration, including housing supports, are effective. And if they're not effective, is it because they just weren't paid enough? And that's our hypothesis right now, based on what we're seeing across the country. We need to pay more for the caseloads that people are being asked to take on in the social sector. And the last thing is, when it comes to value for the community, there's a higher bar that's often set. Researchers have called this the asymmetry of ROI thinking. Mm-hmm. You don't hear people in society say, well, what's the return on investment for that MRI machine? What's the return on investment for that cancer treatment? What's the return on investment for that new pharmaceutical that I just saw advertised at the Super Bowl? The reason we don't ask that is because clearly the business model is a fee-for-service one that usually ends up in profits for somebody. We have an asymmetric way of thinking where we create a bar of expectation that somehow housing and somehow social services and somehow justice has to meet some sort of artificial arbitrary threshold that's much higher than what we often apply to other expenditures, including low-value care expenditures. The point is, when people are asking about return on investment, it's who's asking, but also are you asking the question because you just don't have experience in understanding the core value of this, which is, by the way, it's not monetary, it's the mission. So if you don't get it, then you're probably going to ask questions about return on investment. and that's part of the dialogue, is about how to make sure that we're quantifying it, but not letting the money question be the tail that wags the dog of what is essentially a right.
Thank you. Thank you. We have a few seconds left, and I want to ask if you could each take 5 seconds to let us know what makes you hopeful about the future.
I can start.
Great.
When I started this work 20 years ago, no one was saying housing is healthcare. And now you have hospital systems and major insurers, and you have policymakers who are vested in housing as healthcare. And I am really excited about the tangible progress we've made in even acknowledging the role that housing plays in healthcare.
Others?
I'm relieved that we're having these discussions, even if it's not quite getting over the bar, but just that our policymakers at the federal level are having these discussions about the need to fully fund our housing choice voucher system, about the need to expand access to affordable housing, and about the connections between housing and health. We've got a long way to go, but at least those discussions are happening, which they weren't before.
I just want to say, a decade ago, doctors weren't talking about housing. They were talking about it, but it's kind of a little something on the side. It's front and center. We're talking about solutions that work and taking actions to do it. The government's not going to get out of this by itself. The private sector is not going to get out of it by itself. We're going to get out of this together. And I think that what gives me hope is that we're tracking in the right direction. So this conversation today and the many more that will come after it is what gives me hope. So thanks for letting me share.
Thank you.
Yeah.
Rishi, to you.
This conversation gives me hope, and it's because it's part of a trend that I'm feeling, and I use that word intentionally. I'm feeling it because it's not just about the technical issues and the intellectualizing of the problem or those frameworks. I feel more and more people these days are finding courage and talking about humanity and being vulnerable and love. These are essential things that are at the core of what we do, whether you're a housing provider or you're a healthcare provider or you're somebody who pays for or supports them, or if you're a policymaker. This is about courage. And more people these days are talking about things that they weren't talking about as been said 10 years ago. And it's not just because of policy breakthroughs or research breakthroughs. Those are necessary. But what has been most hopeful for me is the fact that people are finding courage.
Beautiful words from all of you. Thank you so much to our speakers and to everyone in the audience for joining us and sending your questions and being so engaged in this topic. I'm really hopeful about what will unfold after this event. I also want to thank the Institute for Health Policy staff and our friends at Spark Street Digital that we couldn't do these events without. We'll be sharing a link to the recording for others who might have missed it today, that you're welcome to share. And we hope you'll join us again for future forums. Thank you, everyone.